So welcome everybody. Wow, we've got quite a lot of people on the Lunch and Learn today. So I think probably most people will know me. I'm Faye Robinson. I'm Director of Specialist Services, and I'm also SRO for this project. David Ibbotson was meant to have been running, who's Sue Trinder's deputy. He was meant to have been running this Lunch and Learn with Annette, but unfortunately he's been called away as he's doing the urgent emergent BAU on the programme as we speak. So hopefully I'm a good substitute and just give you a flavour of what we're going to be covering today. So this is where I need to see whether it will work. Okay, so what we would like you to learn from this session today, we're looking to cover, first of all, myself just doing an overview of what the programme is, what the National Immunisation Management Programme has been. You'll hear the word NIMS, and Annette's going to take us through the system that we're using behind here, so you've got some real practical understanding of the scheduling dashboards that we're using, the monitoring dashboards, and also the Care Plus. So by the end of this session, we'd like to give you an overview of what the flu and the solution of SCW offers, the understanding of the work streams that deliver the SCW capability. So again, the scheduling of the IMS letters and the recall centre, and how SCW's own data adds value to the NHS England's reporting mechanism. So that's what we're hoping everybody is seeing that we're going to be covering today. So it's not moving over. Jeremy, that's not it's not moving to the next slide for some reason. So if I stop control and I give it back to you,
yeah, and then try it again.
If not, I'll just give it to you in.
So do you want to try that again? Can you hear me, Faye?
Yeah, I can hear you, but it's
maybe
just not
working,
yeah,
is it?
It's not. So if I just I've given it back to you, perhaps you can.
Yeah.
That's it. Lovely. So let me just give you a little. Oh, have I got somebody? Is everybody on mute? Or...
Mute, please, guys.
Okay.
Oh, I can hear some people chatting in the background.
Yes, probably.
Hi, guys. Can you go on mute, please?
Lovely. Thank you, whoever that was. So let me just give you some background. Obviously, we are in COVID. I don't think anybody realizes we're not in that. So I just want to take you through the little journey that we've been on, or a high proportion of the organisation's been on in the last few months. So if we kind of go back to May of last year, we were approached by Julie Hughes and the commissioning team at NHS England on the back of the work that we do within the CHIS services that we run, to see what the art of the possible was. And from that initial discussions with Julie back in what seems to be the very heady months of the back end of May, the NIMS service was thought about, was commissioned, and it has evolved from being mobilised to run for the flu season 1st of September, and has now rolled on to COVID. And one of the reasons for that was, with the backdrop of the COVID season, with the COVID pandemic, the flu season, which happens every year, the flu programme, it was seen as absolutely paramount to make sure that we increase the uptake of vaccinations right across the country. And so some really ambitious targets were set in play, and they needed to get much greater control of data, understanding, and so the concept of a call and recall service, a national call and recall service, was first alluded to. And that's effectively what we've been commissioned. So we are a major part, a major cog within the big mechanism of NHS England's whole vaccination programme for flu and now COVID. And it was also seen that if we could drive the uptake and get the culture of more vaccinations for flu, that would be a good backdrop, as we knew we were going to be hitting some very rocky times for COVID and the winter time. So we're now in the stage of actually starting to almost bring the flu programme to an end, but we have been from dual running on these programs and running the COVID programme formally went live at the beginning of December. So some of the skills and some of the learnings that we've taken from flu, we've been able to roll fairly smoothly into COVID. Just the scale of this particular program for us as an organisation, it has involved very wide multidisciplinary teams right across the organisation. From, if I look at parts of my own service, people from CHIS, governance, procurement, the GIS service. We've had huge amounts of people from IT involved. HR have played an absolute critical role in this, and also from QSP, where the recall centre, our call centre, sits and has evolved both for flu and for COVID. So the scale of it for flu is a programme of around about 250 people who are involved in that, and for COVID, again, slightly larger, around about 300 in totality involved running on the programme. So a real credit to us as an organisation, from a standing start to where we are now actively delivering on two major pieces of work. Very complex, very political. The work we are doing on COVID at the moment, I'm sure Annette will come in and show you some of the level of details that we're doing. It's a slightly different model. It wasn't designed in that way, but it's evolved over the last couple of weeks, simply between working on the COVID around matching where there is vaccine availability to people to invite. Working across the PCN models, as well as the mass vaccination side. So very, very complex, as well as supply issues that need to be managed, which the Army are involved in doing. So our service is called Call and Recall. Call does not mean making telephone calls. Call means, in our programme, the first invite that goes out. So there's a series of different areas which are involved on the calling, from whether that is a letter with leaflets and details that the comms team are actively involved in supporting us with the national comms team, through to SMX or emails that go out to call people. That then goes through a series of waiting for people to take up the vaccine. And then our recall element is for flu was very much more a supportive service to understand why people didn't want to take the vaccine, and to encourage them to take that up. That's been the purpose of the recall centre. If you look at where we are now on COVID, that is being taken a much more active role in driving up, encouraging people from a much earlier stage of when their letters are received to try and drive them up. So our recall centre for COVID went live on Monday. We're now on Wednesday. We know they will have made over 20,000 calls over that period of time, just to encourage people to book in and take their vaccine. Surrounding this as well, as part of the team, is the underlying part of the whole of our service is about improving immunisation uptake. So we also have regional coordinators, regional managers working and embedded within the regional teams to look at what their uptake is, whether that was flu or for COVID, to look at the barriers as to why people have not been taking up the vaccination. So again, really critical work going hand in glove at the regional level to start to drive up the uptake. The database, as Annette will show you, the system that we have enables us to slice and dice the data and that the data analytical team that work with Annette, running a lot of the information that comes in. Again, Annette will talk all the techie stuff to you, is then fed across as well from the regions into the recall centre, which enables us to target in particular ways. So it enables us to look both from a national level, a regional level, down to a CCG level, right down to a GP practice. So we can do some really targeted work on trying to drive and understand why people have not been taking their vaccine. So the three key pillars here: contact with call, talked about the recall side, and then the reporting and planning. So again, a lot of this is dashboard driven, but there is a very powerful tool behind there, which also enables us to do some fairly sophisticated and analytical side. Jeremy, can you move me on?
Yeah, sure.
Thank you.
So, yeah, I think we're kind of handover time.
Okay,
So
that just gives us a bit of a flavour. I just want to mention that we are not in this part alone. We do have two major service providers who are working hand in glove with us, have been throughout this programme, both for flu and for COVID. So we have System C, which is the system provider with in partnership with GraphNet. They are doing the system again, which Annette's going to demonstrate to you. We also have a company called Synatech, which is the hybrid mailer, again, who we work hand in glove between the three parties in order to run the whole of this service. And one cannot work without the other being party to it. So it really is an integral model for us. So Annette, having set the platform, over to you to kind of share and do a live demonstration on dashboards and the system itself.
Brilliant. Thank you so much, Faye. I hope everyone can hear me, and if they can't, start yelling. No, brilliant. Okay, so what I want to do is I want to go through what NIMS is. So I'm going to start sharing my screen with everybody. Okay, so screen one, lovely. Okay, so so here I'm showing you one of the screens that we have within NIMS, which allows us to schedule flu immunisation letters. Now, I think probably the first thing that I should do is I should describe what NIMS is. So I think Faye's done a wonderful job of saying all of it, but NIMS itself actually just means National Immunisation Management System. Okay, so that's what we have. We have this thing called NIMS, and it's made up of the three things that sort of Faye's mentioned. So it's made up of the monitoring dashboards, the scheduling dashboards, and Care Plus. Now, for those of us who also work in Cheers, then you'll know what Care Plus is, because that's the sort of system that we use in child health information services to put all of our information in about the children, and then are able to schedule immunisations from them. And that's how we normally use it in Cheers. However, when you're doing it on a national level, we need something a bit bigger, because the database that holds all of the information that we have, imagine we've got we need to have every single person in England in there. We need to have all of their immunisations, and then we have to have information about their not a lot of information, but some information about what at-risk groups they fall into. So we have quite a lot of information in that. So that's stored all on an Azure database platform, which I think some of you will be familiar with. So that means that the data's sort of stored in one place, and we need to access it in a big way. So what we have for when we need to do a letter run to send out some letters for the first time ever, is we have this scheduling dashboard. So the process goes like this for us. We get a call from our commissioners saying, hiya, could you do us some scheduling, please? Would you please schedule everybody who's 50 to 64 years old for all of the regions? So we say, okay, that'll be fine. So what we do is we get up this dashboard, and it's very simple. And what I'm going to show you is so simple. So you can either go straight to the box like this, click on select, and then it'll come up. If you sort of see here, there's this little whirring thing here. So say I'm going to do 50 to 64-year-olds to the east of England. I just click on the box, and then it comes up with east of England, 50 to 64-year-olds, and then I click send for approval. I'm not going to do this because that will send for approval. So what that does then is that then moves that into another screen, which advanced users have got access to, and they just approve it. It's the simplest of things, just approve it. And then what that will do then is it sends the data from the Azure platform where all the information is. It will move it into Care Plus, which I will show you shortly. It will move it into Care Plus. Care Plus then does a whole series of checks on it, make sure that all the if there's any deaths amongst that group, it will remove them. It will check to see if they've had say an immunization already, so it will take that out. It does a whole series of checks, and then it produces a file which it then passes on to our mailing house, Cinetech, who then just send them out in the post. So it's the simplest of things, really. So theoretically, you just click on this button and then it all flows through. Once that's done, Care Plus itself will then handle all the reminder letters. So in the beginning, we envisaged that once we sent out one lot of one batch, we would then have people say to us, right, okay, so you just remind them, keep reminding them 3 times until they and then once they've been reminded 3 times, or they've had 3 letters rather, they'll then be scheduled a call if they're eligible. So we thought that would be what the process is. What it turned out to be is they actually the commissioners prefer just to ask us if they will say we want to send out reminder letters. So that's more of a sort of a manual process which we get System C to do for us. But the idea being we would kick this off. This dashboard itself is so simple, and the reason it's so simple is because we thought and envisaged at one point in time regions themselves would be running this. But as it turns out, it's better that a central pool does it at the moment. But in the future, it could be that each region will have access just to their top layer, if that's how the commissioners want to do it in the future. So it's the simplest of dashboards. What is a less simple dashboard is when we want to schedule the phone calls. So as I sort of said, people need to become eligible for phone calls. So this here is our flu dashboard. And one thing that I'd like to say to you is just make sure, so I'm showing you all of these things. These are live dashboards. So what I want you to make sure is that nobody notes down any figures and then reports them anywhere. Okay, so make sure that you don't do that. This is not what this dashboard demonstration is for. So which is possibly why I haven't put the COVID one up. So we just put the flu one up, so it's a bit safer. So so when we do scheduling of calls, so this is when people commissioners will say to us, what I need you to do now is I'd like you to schedule calls for people who have received an invitation letter and are in certain areas. So we have 7 regions which we work in, and each one of those regions has got a regional program support team. So they've got an assistant manager, and they've also got a head of. So the head and they work with my team to decide which areas they want to schedule phone calls for. So we go on the dashboard and say that we've got like the east of England. So I'm going east of England a bit. It's just because it's at the top. So what we can do then is if I just clicked on the east of England, then what that'll do then is that just filters the dashboard for me. So this is quite a useful thing. And it takes a little while to run this. If I click on something, you can sort of see it's working on it because it's literally pulling all the latest data. So I can click on the east of England and I go, right, okay, that's interesting. So this is my percentages. So I know what's going on there. But at the moment, say the commission is particularly interested in us looking at, say, the 18 to 64 at risk. All right. So there's a lot you can do here. So we can click on here and then I can go a little bit of a drill through. So I can have a look at some demographic influencers, or I could just send it to the call center selection here. So if I just click on call center selection, which I'm not going to do at present, I can then just basically say everyone in the east of England, just randomly pick some people. But I won't do that. What I'll do is I'll show you that we can actually get a little bit clearer than that. So anyone that uses Power BI knows that we've got a little bit of a filter thing here. So what I want to do is I'm gonna select my cohort. So I'm doing 18 to 64 at risk. So I'll click on that one, and that should give it to me. That's great. And then once I've done that, I want to then go my practice region. I'll have a look, and I'm going east of England. So I'll click on that. So what that's doing now is that's filtering my whole report. So I'm just concentrating on those areas so I don't make a mistake accidentally. So now I'm going to go to the CCG section. I click on that, and I'll wait for it to load. As you can see, you've got the little whizzy bit here is coming to me, and what that gives me is it's going to give me absolutely every CCG in order. But there you go, here's my east of England ones that just happen to be at the bottom. You can order them the other way around. All these other CCGs obviously are not in the east of England, which is why you can't see them. So we could then look at that and say, now I want to go to the northeast, or I want to say schedule for a few of these. Say I'm particularly interested in the lowest performing. I could put them in order of lowest performing if I wanted to, or I could just keep it as it is. I don't want to disturb it at the moment. So I'm just going to go for, I'm just going to say I want Norfolk, Cambridge and Hearts Valley. So what I'm doing is I'm holding down control as I'm doing it. So I've picked up all of those three. So I say I'm interested in those three CCGs and I want to schedule some calls. So as we can see, they're selected on the map. I could have selected on the map instead, but my knowledge of the northeast of England is not good. So I wouldn't have been able to do that. And then I right click here. Oh, crikey, it doesn't want to do it. So I'm going to right click on here and I'm going to drill through to a call center selection. So that should hopefully pull up my dashboard. This is where I find that it's failed miserably. No, it's going well. So that's told me out of all of this that's going on, there's 104,500 people that is in that area, and the number of people who are eligible for me to give a call to are 35,000. So at this point in time, I can then say, actually, how many of those people do I want to schedule a call for? So I can then just put anywhere, any number that I want up to 35,000. And once I've done that, it'll then send for approval. And then that will then be approved by senior members of my team. So that's how we schedule phone calls. It's very simple, but you might then say, well, what's happened to all of that data? Well, I will show you that in a moment where that ends up, because that ends up in Care Plus, where the recall handlers, so the call handlers within the recall center, can then make those phone calls from there. So I'm going to show you now. So that's the scheduling element of it. There is another way that we do scheduling. So Faye alluded to the very complicated COVID scheduling that we're currently doing. So we're working very closely with the GIS team on this. We also have, so in the background, all of this data here, I've got access to it. So I'm not going to show you that because it goes patient level. I want to be quite clear that I don't want to accidentally put something on the screen. So what I've got here is a picture which shows all of the tables that I've got access to at present. So when we want to do the COVID scheduling at the moment, what I do is I send, or I give, or remember my team gives the GIS team some data which we put together. So we put together where the put together the NHS number, and we put the postcode together. And the GIS team, what they're able to do is this phenomenal bit of work, which is so impressive. They work out how far away from one of the vaccination centres those people are, and then they give that information back to me and my team. We then load it up, and then we then give that on to System C, who are then able to process it and then send it on for the letters, just using the data. So just a normal SQL thing that we do. In the future, what we hope is we're going to move to a point where when we're doing COVID scheduling, the COVID scheduling will look a lot like the call center selection that we've had. So it won't be as simple as this scheduling that we do for flu, which is very, very simple. What it will be is it will be something more looking like we had for the call center selection, whereby we've got a map and then we can select people and we can say, please, can you schedule so many people from that particular area? Because we always need to be considering what the vaccination centres are doing at that point in time, how much capacity they have. So we'll be scheduling more like this in the future. In the meantime, yes, because of that 45-minute and because all the vaccination centres aren't being set up, we are very much reliant on the excellent work of the GIS team to make sure that we can actually schedule properly and we can get the right people in. Okay, so I'll move on next to these like wonderful reports that we have. I'm going to show you here. This is the flu vaccine uptake report, and as you'll see, it's really, really, really similar to the call centre report that we had. It's got it's got the same sort of features that we have on it. So down the side, as you can see, we've got all these different bits. So we've got the region, so you can have it at the region level. You can put it down to the CCG level, which again, all these things takes time to load because, and you have to be grateful to it because what I just think is this is pulling off the latest data. So I just, even though I'm a little bit impatient, I want it to hurry up. I have to be careful. So it's turning up. So here we go. We can have like, I think probably one of the things I might mention here is the difference between these numbers. So we've got, as you can see, the number of people that we said were eligible for the flu vaccination is 33,400,000. I'm not going to do all of it, but we've actually only invited 19,000. Now we've run the scheduler and we've invited all of the cohorts, except for some people who have potentially moved into the country. You know, they can move into the country from literally, they can move house, they can move from like Wales to England, and then you know they change their GP, and then they're now with us. So so there is with the exception of a few of those sort of like little anomalies of people moving around the country, we have invited absolutely everybody. But you'd say, well, why haven't you invited everybody? Well, we don't invite them if they have had an immunisation already. So you can sort of see, you know, that we've got here. So if you just look at Barnum Dagenham, so yeah, we said invited and eligible, we've got 74.9%. What that basically means is that they already had immunised 25% of their population. So we didn't need to send them an invite. Otherwise we would have had, you know, it would be sitting at 100%. And then we've got here, so they're doing on their vaccination eligible, yeah, they've only managed to do 25.49%. One thing that we should always be aware of as well is these figures are not always 100% accurate. And the reason that they're not 100% accurate is just it's down to the fact that the data sources that we have. So we get all the data. So our population data is the SDRS. So it's the most up-to-date version of population data that you can get. So we've got direct access to that. Our GP data is phenomenal. We get it we get it from pharmacy systems. We get it from, some of you might have heard of the NIVS app, where people are entering data in. We also have our own NIMS app where people can enter data in the field. So we've got all these different places where people can enter data, and obviously we've got the GP practices which come in. So we find that the EMIS data is coming in very reliably, so is the System 1 data, but there's been some problems nationally with the vision data and the microtest data, which means that is not quite up to date. So what you often find is in areas where there's a significant presence of vision practices, we are missing some of that data, which is a bit of an issue for us. But you tend to find that out quite quickly and easily, because you'll notice that those practices that do it performing really, really lowly, and like you get used to that. And also we find out if they're a vision practice, and therefore we know that we don't need to concentrate our efforts on them. But we hope to have that data sorted. I think IMPS have been working on fixing this issue for a significant amount of time. They just haven't quite fixed it yet. Okay, so we've got it at CCG level, so you can look at CCG. We've also got it at the local authority level, so that exactly it's just going to look the same. And again, you can filter in the way that we were looking at, or you can just click on an area if you want, just click on the map, and that will take you to your local authority, and we'll just show the values for that. Again, we wait a little while for it to do it. I feel like you should have some hold music sometimes when it takes a while. Oh, take a breath. Yeah. So if you use Power BI, you know that there's various functions within Power BI that you can utilize and you can do to get data out. So there's you can export a bit of data just by sort of clicking on here. So you've got export, will show as a table. Add a comment. I don't think I've ever added a comment. And then of course you can do some sort bys. So Power BI using those wonderful things. Also you can use it for can see the filters that are currently on it. So that's fine. So yes, we've got Northumberland shown at the moment, and then that shows, or that should show how it's doing on both, but I think I clicked on something, so it won't do that. The next one that we've got demographic influencers. This is probably one of the more useful things, I think, as well, when we're coming up for COVID, because we have the equivalent reports in COVID. There's a lot of talk about, you know, like making sure that that access to vaccines and uptake is good in all of these particular areas. So we have like so we've got ethnicity, so we can break it down by ethnicity. So you can look at uptake by ethnicity. You can have a look at uptake by age band. And we've got sex, and we've got deprivation. So we have all of these factors, and by using the filters, people can simply use this. It's a very simple tool for people to use and get an idea of how well people are doing according to each of these particular things. So women are being more vaccinated than men, according to this. So more women, percentage-wise, have been vaccinated than more females than males. So there we go. Have been vaccinated, not by much though, just a couple of percent there. And we can also see, you know, some of these things that we might expect. So this is one of the ways that people are helping to look at the look at how we can improve immunisation uptake by looking at some of these factors. And of course we can schedule by these factors as well. So we can literally go in and schedule phone calls, say, to people in the area where deprivation is a bit lower, and then we can hear some of their concerns come through, and we can then pass that information on to the commissioners. But as we can see, you know, uptake increases by deprivation or IMD, and that's quite interesting in itself. We have finally the timeline insight, which is a fascinating one. We really quite fond of this one. So so this shows us the vaccinations over time and how many people we're having at any one time. So what was quite interesting is the popularity of Saturday clinics. So this being Sunday, always the easiest way to work it out because it's the quietest day of the year. But we found that the Saturday clinics are hugely popular, as you can see. And then you sort of like tail off and you think, well, Saturday clinics no longer popular so much anymore. They closed some of them down. So this was very useful. I mean, look at this. So it doesn't mean that the Saturday clinic was not, you know, it was not a popular option. It just means there was less of it. So some feedback went in, and then people were able to put on more clinics, you know, put the Saturday clinics back on. And you get to it. Oh, sorry if anyone sees my cat. Okay, go over there, Edward. Right. We've also got our lovely moving average of completed vaccinations, and also the running total of completed vaccinations here. So all of these reports are, you know, are very useful, and people find them useful to help inform decisions. We send copies of these reports broken down by national level, and then at the individual level for every week to our commissioners for flu, and we will be doing the same thing for our COVID directors report. So it's just a lovely weekly directors report, so they get hold of all this information. And also it's quite good because, you know, it's a fixed point in time. So by sort of like taking screenshots of this, we are actually sort of freezing the data in effect, so we can see how well we're doing. The next thing I want to show you, or the final thing that I want to show you is something that anyone from Cheers, and I've also mentioned before, Care Plus. So here we go. Oh, I've logged out. Okay, so this here, so whereas the other ones were environments where basically it was live data, this, you'll be really glad to know, is actually a test environment. So anything that I show you on the screen, no matter how realistic it looks, is not actually realistic. It's not real data. I had a major problem with this in the beginning because the data was too realistic, and it was based all sort of like in an area where I used to live. So it was quite worrisome. So logging in. We log in by password. There was originally some thoughts about whether we should do a login via smart cards. By doing smart cards, then we'd have availability to the spine, and we'd be able to update the spine with information that we were hearing from people who were calling us. But we considered that, and IG wise, we felt that that was probably not the right thing. Probably, well, it wasn't the right thing to do, because that's not part of our role here. Our role here is to find out about what really taken up the vaccine. So so we basically ended up with a password and username and password to log in, to make sure that we don't have that additional functionality, so that we're not entering data into the system when it's not approved to. Oh my goodness, my cat. Can you go over there, please, Edward? Okay, so one of the things, so if you see here, so it says the NIMS UAT environment, so that is very reassuring, because I know that I'm in the test environment, I'm not actually in the live environment. And then what we have there is we have some lists for people who are able to actually, you can't see that because it's sort of like, oh god, can you unhighlight? Right, there we go. So recall center contact list. All right, so this here is how we schedule calls, or give the recall handlers access to their data. So list of people that they have to ring. All right, so as you remember from before, what we did is we scheduled the calls. So we set it up, we scheduled the calls. All these people in this region, we want you to then ring. So what that does is that brings it into Care Plus. So what I'm going to do now is I'm going to show you a list of all the things. So what that does is it brings it into Care Plus. Now, as you can see, all of these things are assigned to different people. So there's quite a lot of lists here. And if we scroll a little bit further down, what you'll see is it breaks it into like files, the size of which is 180. So each file size should be 180. So the plan being that we would give enough work for people to do over the course of 2 days. So you'll get a file, and on the idea being that you'd work on 90 each day. For further information, so this is just, I'm doing this, so bear in mind, I'm doing this from a data perspective. I'm not doing this from an operational perspective. So for operational perspectives, I will not speak to those. I'm just speaking from a data perspective. So so what it does is it splits it out into 180 per day, and then it assigns. Then previously we had people having to assign them to each person. So you could assign someone. So look, here we go. There's a blank one there. So you just do a little search. So here's my list. I want to assign this, give this to somebody. And it does, oh no, I should be in supervisor mode, sorry. So to do this, I'm gonna have to go into supervisor rather, because there's 2 sections. I forget I have access to both. So if we wanted to assign it, then what we would do is we would just wait for it to load a bit more. There's so many on here. So you'd find a blank one, which I know there is because I just saw one. Oh no, no. I'll just show you on this one, and will not take miles off. So yeah, you just search for it, and then you would know people, the code being the user login. So if I was to do that, I would click on there, then I found myself, I would just click on that, and then that would then assign me to this particular one. But I'm not going to do that, because then poor Miles will be without his list. So once you've got your list assigned to you, you go into Care Plus. So each user in the recall center has got a different view. So I've got access to everything, because I'm effectively the system manager, so I should have access to everything. So I've got I've got 4 things down the side, whereas they don't have this. It's a much shorter menu for them, so they know how to do it. So they come in the morning, and then they would click on their list, and in that, bear in mind, test patients, everybody, test patients. So they see here, so they've got these people here, so that they have to ring. And what they'll do then is they'll click on the NHS number, and then they'll go through their call script. So I won't pretend to understand fully the call script, because I didn't write it. And I think it's a phenomenal call script, I know. So they would run through all of this stuff. And as they were talking through each bit, what they would do then is they would then enter into any information. So we've got here the defined test. So contact made. So what I think, probably after you've been using it for quite a while, you'll know all of the codes, so you don't have to do this. But you can do a little search. So they'd sort of say, okay, so contact made. So you've got the option to do the left voicemail, unable to leave voicemails. You've got all the different attempts, and then you could then sort of say yes, we made contact, Were they happy to proceed with the call? Again, just by doing a search, you'll be able to find all of them. Do you want us to attempt to call you again? To pass the security questions. So each one of these has got a little answer, and then we can then put, they can do some free texts if there's some extra information. The free text is very popular with the commissioners, I'd like to say. The commissioners are a little bit obsessed with the free text. They like to read what was in the free text. So they'll go through that. So they go through the whole thing, and once they've done, they'll just press save, and that then leaves that particular call script on the on the patient's records. We're calling it patients, but it's actually eligible individual is the term that we use. But for Care Plus, it's sort of patient, but yeah, it's eligible individual. And once that's left on, that information. So each bit here, if you can sort of see here, if you answer yes and yes to these, and that, or if you answer yes to contact made, what that will do is that will take this person off the list, so you don't have to call them again. And there are various points in this which are terminating, which means they'll just take them off. If, however, you didn't push yes on this, so I'm just going to delete that. I'm going to say contact made. I'm going to say no, wasn't that? Well, actually, it was attempt left voicemail, and then you press save. That then, when you go back to your list, that person will still remain on your list, so they can you still know that you still have to call them. So I go back just to prove the point. Oh crikey, I don't know if I remember who the list was. So hopefully top, yeah. So Miles there. So yeah, so he'll still have at the top of his list that they've done that, and they've made one contact, and the date that the contact was, so they know as well. So that's another thing. So people get called, you know, so they have these lists to do, so they have to call them up to 3 times to see if they're in, and they make contact with them, and so they know by looking at this that they've got another few times to call them, but then they also know not to call them back on the same day because it's presented on the screen. And the same works for COVID, so exactly the same thing. So they'll just have lists, and each person will be assigned either to the COVID bit or the flu bit. So they will get those lists according to which part they're in, because we've set it up that way. And I think that there is pretty much all of NIMS I've shown you.
Thank you, Annette. That's really, really useful. And you know, you've taken me to some areas that I'd heard about but hadn't seen in demonstration. So that's been educational for me as well. So thank you. Before we kind of throw out to any questions that people may have, I think what Annette's taken you through has been a very whistle-top tour of what the system is. There is obviously sat behind here an incredible major data flow between all the systems that feed NHSD and then comes back into System C, and our role within this programme of then feeding data back up to the Foundry, and that's what you'll then see published on the government website. So our accuracy of the information here is critical to ensure that those things, the information flows up to the national systems. Particularly great to see the figures which are quoted almost on a daily day on COVID comes from our dashboard. So we have kind of front head runner as to what those figures are being for, certainly for England. Well, it's the only area we're covering. Obviously, when you see the figures that come in on the government website, it also allows it for Wales and Scotland and Northern Ireland, etc. The data and the system that Annette's just taken you through, it just goes to demonstrate again how, as a multidisciplinary team, we have played this as a programme. Everybody, you know, right across the organisation is involved in this. The power of the system on being able to work at the regional teams down through to translating from the regional heads as to where the regional teams want to focus. Annette showed you all the way down into the east of England, then right down into performance levels of CCG. That gets overlaid with some of the intelligence that happens on the ground as to whether there is a particular issue with a provider, so the vision data, or whether GPs just aren't vaccinating in a particular area. So I think, Annette, what you've just pushed up there is the complexity of where we are working within this particular programme. So ours is the kind of purple bit there on the NIMS side. So this is the first time ever that there has been a national reporting system for vaccinations. So you can see that the commissioners are really excited with what has been delivered as part of this programme. The feedback from the regional support teams has been phenomenally helpful. They've been able to use the data. They've got access to the live information here. And again, the first time ever they've been able to report nationally. We all have seen the pressure that's been put on, daily figures of vaccinations now achieved. That is coming from the programme of work we're doing. So I'm incredibly proud of every person who has absolutely slogged their guts out over the last 8, 9, 10 months as part of this programme to get us to where we are. And that is also presenting us with a range of future opportunities, which we're again now starting working on. Believe it or not, we're now into working for flu season 21-22. The flu season technically ends at the end of December, but there is still vaccination there. So if we've sent you a letter, please make sure you go and get your vaccine. If we sent you a letter, if you're over 50 and you've had your vaccination and you had it previously to when that letter was sent, please just drop Annette an email and she'll investigate why, because she loves that kind of thing. We have got some of those which we've done over the last couple of weeks. And the future is really quite bright for this programme. What we are looking to do is to take the learnings from both flu and from COVID. We are looking at further enhancements, which will be quite exciting on things like AI technology and working with our digital teams as to how we can explore to enhance the service further as we move forward. So that kind of blend from this as part of the system that Annette's been showing you, but how we can support and accelerate in other areas as well. Those are the areas which we're starting to develop on. Again, incredibly exciting project we've been involved in here, and fantastic to see as an organisation that we are at the heart of what's going on COVID currently. You will see it doesn't get branded anywhere. This here is a System C GraphNet diagram. It doesn't get branded as System C or GraphNet on any of the reports that go in. It doesn't get branded as SCW in a lot of the systems. It's branded as NIMS and it's NHS as NIMS, so that the people who know that we're behind this know, although Louise might tell me slightly differently, I'm sure, if we're branding it in a different way. So that's it for the lunch and learn. We've got about 12 minutes left, I think, Jeremy. So is there any questions or anything anyone see? And I can see there's been quite a lot of functionality chat there. So I think a lot of people have found it useful. But is there any chat, Jeremy? If I just pass it back to you to handle any of those questions that people may have.
Yeah, people can give audio questions to yourself if you like, Faye, and to Annette. I can monitor the chat there. So the block diagram is really informative. Can this be sent as well, Annette? I guess that's a question for you. Super on screen.
The screen. Oh, this one.
Annette, can I answer that one?
Yeah,
we can't share that. I'm not sure where that's come from. Maybe if you can just have a chat with Annette offline. We have had some approaches from people asking, can you show us all of this? And obviously what is up there is it's quite powerful for somebody who may be wanting to come and design something else. So would not want that to be kind of shared openly.
Jonas, that came from Jonas Williamson. So Jonas, could you acknowledge that? So I think for the moment it's sensitive to the project. Thank you.
Thank you.
Any more by text or to actually speak to Annette or Faye?
Okay, so there's one there. Will we?
Yeah.
Okay.
Sorry, that was a typo.
Whoa.
Will we publish or announce that we have been in such an important player in this process going forward?
Yeah, so Louise, do you want to handle that one? I know you're on the line if you're still there. And you're on mute.
Yeah.
First time ever I've had to say that today.
So I didn't talk on the previous when Annette was talking. Hello, I'm Louise Bowden from the communications lead for this programme. There are so many players in this programme, and obviously massive national and governmental sensitivities when the flu programme started and as we moved on to COVID. We've been able to put some information on the SCW website about our involvement, but for sure with Jeremy and I, we've got a number of different case studies, stories about the things that we have done that we're hoping to share on flu very shortly in relation to the work that we're doing on COVID and all the coronavirus vaccinations. At the moment, we're very silent externally on what we can do, what we can share on that. But absolutely, the intention is down the line we can share more information and also share more information internally via the loop. Whenever we hit a milestone, we try and share as much information as we can, but there's lots of, as you can imagine, there's lots of sensitivities. Thanks. Thanks for the question.
So there's one there from Sophie Wickings. How is the programme staff, DG, call handlers, etc.? Who, how many are SCW? I may have missed this earlier. So, Faye, do you want to take that?
Jeremy, you're on mute now.
Oh.
No, he's not. I can hear him.
Shouldn't be. I think it's about the call handlers. So we've got, Faye, do you want to handle that?
Yeah, so numbers of call handlers for flu. We have had, again, fantastic support from the HR team led by Paul O'Toole. Paul Toomer, sorry, not Paul O'Toole. Got his name wrong. How can I do that? So Paul has been supporting on the HR side, and we've been working with a blend both of SCW teams. We've had people who have come in on our bank, and we've also used 2 agencies to recruit in call handlers for flu. These are programs of work currently. It's not so although we have developed a service and a service offer, we have to recognise that the contract lengths of these have lent themselves to using different blended models of call handlers. What we are now working towards is how do we make this a sustainable long-term service, and then our model will evolve and change. We've also had some people who have got backgrounds. We've employed people who've got absolute backgrounds in working in commercial recall centres, setting up and advising us on this. This has been a big programme of work. Just to put you the scale, we talked about 180 call handlers. That's what operates on a daily basis for flu. It's around about 240 for COVID. But we have a pool of people that sit in behind. Obviously, this is shift work. So we have some people who work part-time on this. The call centre operates 7 days a week, so it's flexible working for some individuals. But there is, as you would expect in the nature of this type of work, a high turnover of staff as well. So we have been very lucky with the flu programme that once we went through the initial turns of individuals, we had people who've stayed with the programme of work. Again, it's a sad indictment of what's happening in the country at the moment. We have a huge demand. We have a huge supply for our demand, but we are also competing in this particular market with test and trace, with inbound call centres, and a variety of others which are running at a pace. The other part, which again we've used different technology, so from the flu programme, we were using technology of people us supplying kit through our IT team. We've done something different for COVID, which is a bring your own device part for the recall centre. Again, phenomenal piece of work that the IT team have worked with IBM to bring that to life, which has worked. There were some initial issues with a part of the flu, which we've been able to address as part of COVID. So as far as the numbers are concerned, a kind of a blend of people that we've got there, and again, an evolving model of workforce. Jeremy, next one.
That's it. Just a comment, not a question anymore, guys. We've got a minute or so left.
Jeremy, it's Debbie Priest, team leader, team 1, call centre.
Hello.
Hi, I did put one down there about the IMS service generating more awareness, you know, in the daily updates and things like that. Do you think that will be something that will happen because we are such a big part of this programme?
Mention on the, did you say BBC?
You know, like
and
when, yeah, like when Boris does the daily updates and things like that about, you know, people will be contacted by the IMS team, or is that something that's too broad for them to say? Or could it be something where we could just get a bit more exposure on the NHS websites?
Be lovely if we could, couldn't it? If Boris could point his comments towards us.
Yeah.
I don't think so, Faye. I mean, so at the moment we do for flu, and myself and Louise are lobbying our NHS contacts to have more kind of identity on what we're doing. But it's on the COVID website. We do have mentions on the government.uk website and on the flu website. That's to help the call centre, perhaps with kind of authenticity around calls, people know who we are. But I think it's a fine line between kind of identity with SCW, because we're commissioned to do this work by NHS England, who are the kind of in the seat for this, and we're you know, an important, crucial partner in the background delivering all this fantastic stuff.
Okay.
Faye, is that about right?
Yeah, it is. And Louise, I don't know whether you're still on the line, whether where we are trying to get those included, certainly in the letters that are going out for the awareness, have been alerted that there has been issues with you know, people not wanting to answer their telephone or seeing it as a rogue number of some type. Louise, do you want to pick that one up?
There is, as we'd always anticipated for both flu and for COVID, some concerns about the legitimacy of making outbound telephone calls. You know, someone phones and says, "Hello, I'm from the NHS. Give me your you know, can you confirm your date of birth?" So we always knew that there would some people who would have concerns about that. So to help mitigate that, Jeremy and we've got more information into reports that go to GPs. So primary care GPs know that who we are making our outbound calls to, and some of that information is now appearing on GPs' own websites to provide reassurance to their patients. We're hoping to be able to get some more information into the COVID letters as they go out, so people are aware that there is a follow-up, potentially a follow-up outbound telephone call, and also to get it mentioned on the national booking service as well, on those websites. So for the call handler teams and the team leaders, we're doing all of that for you. It just is, we are one cog in all of the things that are going on. But hopefully something of that will happen soon, Debbie. Thanks.
Oh, thanks Faye. Louise. Thanks, Jeremy. Thanks, Faye.
Thank you.
Okay. So any final questions come through, Jeremy?
Yeah, we have a long one here from Ross Mutum. So Ross, I don't know whether you want to add to this. So access to COVID data is understandably heavily sought after right now. Neff's been very patient in responding to my questions around what COVID data is available via NIMS. And I know that there are moves to make reporting available via the Foundry that may provide what systems are needed. But is there any update on whether any data could be made available within SCW? So I think this has partly been answered, but Faye, do you want to handle that one?
Yeah, what
data
I would
share.
So the data sharing, obviously paranoia rules, I think is probably fair to say. Mine, we're being recorded, aren't we? So I probably shouldn't say that.
So I'll scrub that.
Yeah, thank you. So data sharing, we are bound by our DPIA. Our governance team would absolutely shoot me if we released any information that we're not able to do, and that's even within the SCW family. It has to be done for the purposes in which we have been collating it. Let's take that one offline. Annette, can you just link that one through with Jeremy so we can have a bit more of a detailed discussion as to what information people are wanting?
Absolutely.
Yeah,
thanks,
thank you.
guys. I think we're coming to the end now, so I'm just conscious of whether this will actually time out. I don't know if Kerry's on the line, whether this will actually time out on the invite which she sent round, but I think we're pretty much there. If you're happy, Faye, I think, and everyone else, I think we've had quite a few questions. We could probably close.
Thank you, and thank you all for your time and your interest in the programme. And again, my personal thanks to everybody that's been involved. you know, it has been an absolute multidisciplinary team, huge amounts of people been involved in it, and it could not have been done without the support of everybody within this. So thank you.